This podcast is intended for veterinary professionals. Whilst members of the public are welcome to listen, please note that the discussions are designed with a clinical audience in mind and may include technical or treatment-related content. If you are a pet owner with questions or concerns, we always recommend speaking directly with your own veterinary surgeon who knows your animal best.
Hello everybody, hello listeners. Today's podcast is going to be the current status of intra-articular medication in the small animal patient. I'm Greg McGarrell. I'm not a veterinarian. I have a background in orthopaedic tissue engineering, and I'm joined today by Russell Chandler, veterinarian, who will introduce himself.
Thank you very much, Greg. So I'm Russell Chandler. I'm a vet who's got a special interest in regenerative medicine. And here we are live at the VOACON 25. And we've just taken time out to record this podcast on this very important subject of where we are with intra-articular therapies.
Okay, thanks, Russell. I think probably to kick it off from my point of view, I've had a lot of experience in the equine market in the veterinary profession, where I suppose the idea of intra-articular medication is very much standard there every day. We know that horses get their joints injected to manage what we would regard as early stage osteoarthritis disease, also known as synovitis. It is used in human medicine. Probably not as much as it is in equine medicine, but we are now starting to feel the influence of tackling disease such as osteoarthritis by using intra-articular medications. Now, you and I, we've got a lot of experience in this area. We've had a chat before this. When you actually look at where we are today and what is available, so intra-articular medication has been around a long time. You know, it's not new, certainly not new. It's been around for decades. And the breadth of what is available, well, we start with traditional pharmaceuticals. We're all familiar with corticosteroids. Corticosteroids are injected routinely in equine medicine. They're routinely injected in human medicine. Not so much in veterinary medicine. So before we get into that, let's touch on steroids at the moment. What's your opinion? Why aren't small animal vets using corticosteroids in joint medication?
Well, as we know, corticosteroids are very, very effective anti-inflammatories, probably the most effective anti-inflammatories. And when they're given intra-articularly, they are particularly effective in those acute, effused, swollen, painful, hot joints. Yeah. Now, there is a downside, and the downside is the more you give them, or the more repeats that you give, the more damage, the more destruction, we believe, happens to the cartilage. So I think small animal vets are quite conservative in that way. They don't want to cause harm. So I think it's really fallen out of favor as a small animal treatment in these joints.
But what about those that are chondroprotective? Triamcinolone has been shown to be chondroprotective, relatively short-acting, not like depomedrone. So triamcinolone is active in the joint for 56 days, blocking prostaglandin at 96% for that period of time, and then dissipates thereafter. So if you look at how it's used in equine medicine, it's highly effective at those initial flares, what we would regard as a sort of destabilized patient initial presentation. So your ability to go in and block prostaglandin, which when we think about our approach to using NSAIDs systemically, which is what you're actually trying to do with your NSAIDs, but at a much lower level, systemic, whereas if we were to consider it, and that's what we're here to talk about today, the use of potentially a chondroprotective corticosteroids could be an option. That's what we're saying. It shouldn't be discontinued. It shouldn't be not considered. Mm-hmm. We should consider it. It is an option.
Agreed. You make a very good argument, especially about the duration of action and the fact that it's relatively free of side effects. It's not a licensed product, however, and that is a downside.
Yeah.
And the other, I think, contraindication or the the reticence arises in people's minds from the fact that they're probably going to want to use or need to use a non-steroidal anti-inflammatory, and the combination of steroids and anti-inflammatories, that's not a good combination. That's contraindicated. So in a situation where I've got the option of injecting a long-acting steroid into a joint, where I think that patient may well need some non-steroidals pretty soon, means that I kind of need to make a choice. Which way am I going to go? So that is probably, I would guess, the main reason why people aren't reaching for the triamcinolone.
True. But let's finish a bit by, I would say that it is used in equine medicine. So although it is not a licensed veterinary medication, we do see wide use of it in veterinary medicine. So it's in the arsenal for people to use. It's very inexpensive. But you're quite right. If we're thinking about longer term use or longer term stabilization of that patient, there are probably better ways to approach it. So where we're going right now is we touched a little bit on steroids, but really what that did was it opened up what do we need to choose as far as all the products that are available, and we'll try and touch on them all in this podcast, where and when and what is the expectation. So with the advice that I try to give on the selection of intra-articular medication is try to classify the status of the patient into what I regard as three stages. One is the destabilized patient, which is your initial presentation. It might be the first time the patient has been presented to you having a lameness. That might have been ongoing for quite some time, or it could be an acute situation, even in a situation of a working animal or a sport dog. They're very quick to pick up what would be a subtle lameness or a subtle situation, even a synovitis, but it's still what we would call destabilized. We don't really know what's going on. We then have a period where we would then stabilize the patient. We're taking into consideration all the symptoms, the pain, the comfort, the welfare of the patient, and then we're moving into what would be management of it. Now, when we consider those three aspects, what I then try to do is narrow that down into two, which is, are we working with a catabolic environment, which tends to be the first two phases, the destabilized and the stabilized, and then moving out of that catabolic environment into what would be an anabolic environment for disease modification, disease management. So your treatments would really follow two pathways. Is this a symptom modifier, or is this a disease modifier? Now, to confuse that even further, some of the treatments can do both. And that will really need to be clarified in your mind as to what you're expecting it to do. So, classic one, I'm sure we're going to get into stem cells in this discussion. No one ever ruled it as a one-hit wonder. We might need to use that medication at certain different time points, and it might be that medication will achieve a different result used at a different time point. So to look at a biologic used in a destabilized, inflammatory, catabolic environment would make that biologic work differently. Say if it was into a more stabilized patient, moving it more into a management and how we can manage that patient and get it onto a path that is managed.
Agreed.
Yeah.
All very good points there, Greg.
Yeah.
Maybe we should take it one step back, and I like your categorization of destabilized joint versus stabilized joint versus joint that needs disease modification or the long-term management type situation. But taking it even further upstream, maybe we should think about the diagnosis and where we go. One of the downsides of being in the field of treating osteoarthritis is a lot of the time animals get treated and the diagnostic workup is either incomplete or completely lacking. So I think we should maybe touch on, how we diagnose these patients and how we categorize what we're dealing with.
Yeah, and I've talked a little bit about my work in equine. Typically, when we see equine patients, it tends to be a single joint because it's so early on in the disease process. And we see that in equine medicine where we can target our intra-articular medication to a single joint to relieve the overall condition of that patient. Whereas in small animals, tend to see the condition much later on that might be affecting multiple joints. And what we're talking about with intra-articular medication is delivering a local medication, not a systemic medication. So we do absolutely need to be on the point with the joint that is affected, Are we dealing with a single joint? Are we dealing with multiple joints? How we deal with a multiple joint situation if we are going to go down the intra-articular route? What's your view?
Yeah, well, I agree with that. And furthermore, if you do have a small animal with multiple joints affected, all those joints may be at different stages of the pathology.
What is primary? What is secondary, tertiary?
Precisely. So I think in terms of investigation, obviously we can take it as read that we do a good history. We take on board what the owner is telling us. We do our clinical examination and we're looking for joint effusion. We're looking for heat. We're looking for range of motion. We're looking for all those things that we'd normally do with our joint examination. And then, we'd be looking to confirm or refute our theory as to, is it an acute problem? Is it a chronic problem? We might do things like radiography. We might do things like ultrasound. We might do things like joint fluid taps. And the joint fluid is a very important one, in my opinion, because that is able to give us a lot of information.
Right, I'm going to throw you my first curveball. What about joint blocking? What about the small animals? Regional analgesia to confirm or deny that joint is the cause of the pain.
Theoretically, it sounds good. Practically, I've not actually done it particularly much. I'm not going to say I've never done it, but it's not part of my routine workup. So what you're talking about is what's done in horses, where if you were to suspect, say, I don't know what they're called, fetlock joint?
Yeah.
If you suspect that it's the fetlock that's affected, then you may numb the fetlock or put in local analgesic into the joint, leave it for long enough to completely desensitize that joint, and then trot up your horse once again and see whether that lameness that you had pre-injection has now resolved.
And that is identification. That joint is the affected joint.
Yeah.
And that is normally the prerequisite to a equine intra-articular medication. That might be, going back to our original point, why isn't it done more frequently in canine? Is because we have a difficulty with the diagnosis, either ruling or ruling out that is absolutely the joint that needs to be injected.
Exactly.
And we have multiple joints. So with a multiple joint situation, it's probably better to go down a systemic pathway.
It might well be. I suppose the thing that's closest to that as an analogy is very often you'll get a forelimb lameness.
Yeah.
And you will be thinking, I'm not quite sure. Is it the elbow? Is it the carpus? Is it the shoulder? What's going on? And then your radiographs will be equivocal. And then you'll think, maybe I should do a joint tap. You tap the shoulder and you get out a significant amount of synovial fluid, then you can be pretty certain that there's pathology in that joint. So I've done that many times. I'm not sure if it's an elbow problem. I'm not sure if it's a shoulder problem. You stick a needle in the shoulder and 3 or 4 mLs of synovial fluid come out. You know that there's a problem in that joint because that effusion should not be there. Okay. So I think that is helpful.
So that's synovicentesis. I mean, to the GP there, if you were to do this, trying to help your diagnosis, are you looking at colour? Are you looking at shear volume? Some of us know forgive us, the tacky test, where you rub your fingers, your gloved fingers together to see if it forms a string, which it should do, versus that watery consistency of a more inflamed joint.
Yeah, you're talking about viscosity there.
Correct.
Exactly. For me, it's mostly done on volume. And if there's any significant volume, if it's readily tapped, then normally that's abnormal. So volume is the first thing. Obviously, if it's not clear, then that means there are a lot of cells in there. And that usually means there's inflammation, which usually means infection.
Yeah. What about that hemarthrosis? Are you scared about that, especially when going to intra-articular?
I'm not scared about it. I mean, you mean to diagnose it or to cause it?
If you've got presence of it.
If you've got presence of it, then that might give you certain clues as to what the pathology is.
Good.
But normally with synovial fluid, you're trying to categorize on the cytology. Mm-hmm. Are we dealing with inflammation or are we dealing with degeneration? Yeah. So those are the two main categories. So in-house, in your own lab, as long as you can make a smear and stain it, and as long as you can identify what a neutrophil looks like or what a mononuclear looks like, then you can do a differential count. And 9 times out of 10, you can differentiate between a degenerative problem, which is going to have a predominance of mononuclears, against an inflammatory condition in which polymorphs are going to predominate, maybe 90% or more. If then it's only one joint that's affected, the most likely cause is infection, like a bacterial infection. If it's multiple joints, and especially if it's symmetrical, then we'll be looking at a polyarthritis. So we'll be looking at a systemic condition, some dysfunction of the immune system.
Yeah.
So I think having that as a skill, having that as a tool, being able to tap joints, at least the main joints, elbows, shoulders, stifles, if you can do that, that can give you a lot of information very, very quickly, just from looking at the fluid, as you say.
Yeah.
How much fluid? How clear is the fluid? What color is the fluid? Is it viscous?
Yeah.
What's the cytology like? All of that can be done in a very short time.
And doing that simple slide
Exactly.
is objective. You're going to see those cells. It's going to guide you
Exactly.
down that diagnostic pathway that
Precisely.
I do have something going in that joint.
Precisely.
It's going to confirm and allow you to go, what am I dealing with?
Precisely.
The other thing I like about arthrocentesis, getting a needle into a joint to remove joint fluid also removes, if you have got an inflamed joint, confirmed by your slide, you are also removing the overburden of those inflammatory cytokines.
Agreed. And furthermore, probably reducing the pressure in that joint as well. And just removing the fluid very often seems to have a therapeutic effect.
Well, you look at, patients that have been scoped, arthroscopy, they recover incredibly well. Interestingly, they've had the entire joint flushed out.
Exactly.
Yeah.
Exactly.
Horses stand up without a problem after arthroscopy. I mean, I know it's very common in German human practice that a joint is flushed prior to any intra-articular medication. Do you think that's useful to remove that overburden?
I think it is. And going back to your earlier point, once you've flushed and removed that soup of cytokines and inflammatory cells and what have you, inserting some local analgesic, or even opioid, or both, is also, probably beneficial.
I know there's a current trend in equine medicine, not for diagnostic purposes, but prior any intra-articular medication, to use something like bupivacaine. Now, yes, it's renal analgesia, but it's also anti-inflammatory. So bupivacaine has anti-inflammatory effects for about day and a half, 2 days. So that's also beneficial. It's going to wear off quite quickly, but it is an additional benefit that if your choice of intra-articular medication, provided the two don't, contradict each other, is it's going to aid in potentially what might happen, especially in the disease modification stage. That if you're actually wanting the environment to respond to a modulator or something that's going to create new tissue, we certainly don't want to be fighting inflammation.
Exactly.
Nothing proven there, but I know that there is a move towards using, regional analgesia like bupivacaine to assist in that intra-articular environment.
Absolutely.
Yeah.
So if I could ask you then, Greg, supposing you had a case and maybe a veterinary surgeon came to you for advice and says, either one of these, I've got this joint, it seems to be acutely effused and inflamed. I want to put maybe a biological or some other intra-articular in there. What would you advise, as opposed to if the same vet came to you and said, well, I've done a joint tap and it's a chronic situation, mostly mononuclears, and it looks like a chronic OA, and I want to use an orthobiologic. Is there any difference in what you'd advise in those two scenarios?
Yeah. Okay. I'll probably lean a little bit towards equine, if that's all right. But there is a crossover into canine. So if we're dealing with the acute inflamed joint that's initially presented, if you're going down the biologic, I think my choice would be more towards what is new, the A2M molecule, the alpha-2 macroglobulin. What we're dealing with here is, and the way the A2M molecule works is to remove the MMPs. So it's a molecule that, in a way, works like phagocytosis. It grabs the MMP, which we know to be deleterious and know to be a responsive aspect to synovitis. It removes them. So it does calm the joint down quite quickly. The A2M molecule, it's a...
Can I just clarify there for a minute? MMPs, by MMPs, we're referring to
Sorry, matrix metalloproteases.
Yeah, so these are the enzymes that are responsible for breaking down cartilage.
Yeah, and in the situation of the RA patient, we're typically worried about 3, 9, and 13. Those are your real nasty MMPs, which the chondrocyte produces through normal cartilage turnover in response to IL-1. We need to be all day talking about that one. But we're talking about the inflamed joint and how do we stabilize the inflamed joint. The A2M molecule, or even the IRAP, which was we have the anti-inflammatory cytokine interleukin-1 receptor antagonist protein, which blocks the action of IL-1. We know that is inefficient in volume when we've got a synovitis or a chronic synovitis. The synovial membrane is responsible for producing the majority of IL-1RA. It's without question that if you've got a chronic synovitis, that you're going to have a lesser amount of production of that anti-inflammatory cytokine, that blocker. So what IRAP, typically, the phrase IRAP was coined by a company called Orthobiologics, who brought it out. It stands for interleukin receptor antagonist protein. We also know it as ACS, which is the autologous conditioned serum, which is where you manufacture the autologous IL-1RA. And that is anti-inflammatory. That's an anti-inflammatory biologic. It's relatively easy and cheap to manufacture. You would culture the blood over several hours. Essentially, you are stressing the leukocyte in a clot environment, cultured at 37 degrees, to produce that protein. And you can harvest that off, spin it off, and inject it back in.
And this is done patient side?
Yeah, it's done patient side. But it can be frozen for multiple weeks.
And how many hours does that take to make that?
So you can do it in about 7 hours if you use the smaller 10 ml tubes. Or you can do it over about 23 hours if you're using the 60 ml.
Yeah.
It's just a volume. It's a volume thing relating to the time. So we know that A2M and autologous conditioned serum or plasma are targeted towards an inflammatory response. That's a biological of choice there. That's pure. Now, it's probably worth touching on, would you put a stem cell into an acute joint? Now, this is where we start to stray into what you said. The second one was if you had a more chronic joint that really wasn't inflamed, but the patient has now sort of, come to, to terms with living with this chronic joint. It's now presented to you as a chronic rather than acute flare. I suppose this is where you start to go, could the two end up in the same place? Because we know, let's talk about stem cells for a second, they can be used in the inflamed environment and they could be used in the chronic environment. So I'm not saying I wouldn't use a stem cell in an inflamed environment, you just got to know what you're trying to do with it. Exactly.
So, I agree with all of that. One thing you didn't mention was PRP. Would there be a place for PRP in that acute situation?
Oh, thanks for the tough one. I'm going to say no. Right. Only for the fact that in most situations, people don't know what they're trying to do with a PRP. All right, and I'd say, and listeners, please don't shoot me for it, most people don't go beyond the platelet. They think the platelet, we've got to get past the platelet. It's about the growth factors in the platelet. And you've got to analyse what the growth factors do. I think PRP is a fantastic therapy, and it does work. Growth factors and platelets are essentially their every day of healing. It's what the body responds to. But when we go into growth factors, whether you're looking at PDGF or TGF-beta or IGF, these are all stimulatory growth factors, and they are very good at stimulating. There are, to a degree, anti-inflammatory capabilities within some of those growth factors. TGF-beta has that capability. But for me, they're more stimulatory down a sort of an anabolic pathway. So if they were to work, they're not working directly. They would be working by changing the biological environment or even working on tissues to help aid the repair. And those tissues repairing and changing the environment of the joint, they themselves would alter the inflammatory response or the inflammatory situation. So where we've got, the production of biologic that goes straight after the inflammatory target, PRP would take an indirect route to attack that inflammatory environment. Yeah. So I think for me, PRP is probably not used in the destabilized patient. I think it can be used in a stabilized patient prior to moving into disease management, almost how you would say preparing environment for a skin graft. Okay?
Yeah.
There's a sort of medium environment where I go, I need to prepare the area for what it's about to do, and the PRP is very good at warming the environment up, ready for a modulation or that tissue response. But I think you're probably asking too much of the PRP and too much of the environment, and certain circumstances where you can end up with a PRP flare if the joint is inflamed.
Yeah.
Some of the action that the PRP is doing could have, dare I say it, a inflammatory response, but a positive inflammatory response. I mean, if you look at TGF-beta 1, I hope I'm right, is pro-IL-1. So it actually elevates IL-1. So you've actually got a cytokine there that is elevating that inflammatory cytokine, to which, to a great degree, we're trying to decrease. But it does it in a reparative way. So again, sometimes you could stir the pot too much by using PRP. Yeah. But let's go back to it. Point we made earlier. If you were to remove that overburden through removing the synovial fluid, then put PRP in. Yes. It's a different situation.
Yeah. You'd probably rather have some decent PRP in your joint than you would have that synovial fluid, which is full of those inflammatory cells and so forth. Yeah. And there is evidence that you can get a direct analgesic effect from the PRP as well. Yeah. Mediated through 5-HT. So, it's complex. I hope the audience understands that what we're talking about here is there's a lot that we know, and there's a huge amount that we don't know. And whereas we're trying to kind of just give the facts, there is also some discussion around the speculative side of things as well.
Yeah, I guess it also, I mean, we've discussed what can be used intra-articular, and the list is quite long. And what you don't have is a go-to, whether it be a biologic or a pharmacological product that is going to do everything. What you have to do when it comes to intra-articular medication is do your homework, understand the etiology and pathology of the disease, understand how a drug or a biologic is going to interact or work at those various stages, and choose your tool appropriately. You don't use a hammer to drive in a screw.
Exactly.
It'll do the job, but it might not do it quite as cleanly as you'd like it to.
Exactly. So in the acute situation, I mean, in summary, probably tapping the joint is good.
Yeah.
Maybe going for some IRAP, possibly PRP.
Yeah.
And then obviously good analgesia.
Yeah.
So
still wouldn't rule out steroids.
Yeah. So on the other side of the divide, then what about those chronic cases where we know that the joint has got osteoarthritis? There isn't any instability. Because of this instability, such as a cruciate ligament rupture, then that's a surgical situation. Let's say we've got a stable joint that has OA, chronic, and we want to use an orthobiologic. What are we going to do in that situation?
The orthobiologic there, I think, would be your stem cell. You've got an environment now that is not catabolic; it is stabilized, and the joint, to a certain degree, is able to balance the situation. The synovium, to a degree, is doing its job. We've got to take into consideration the environmental factor. A stabilized patient could destabilize quite quickly. So we do need to keep these patients under control, whether it's really strict exercise regime, home environment. Those things are hugely impacting on our next bit. But I think what we're getting to is, could we improve the joint environment? And what we're after today is really improving the function of the synovial membrane, the joint capsule. There are things that we can do to the cartilage, but that tends to be very slow in response. We do see a regeneration of cartilage, but really the true impact that we can get is the health of the joint by targeting our approach to the synovial membrane and the soft tissues. And the nice thing about a stem cell in this situation is that they are a modulator. They have the ability to go into the joint, read the environment, especially if it's not an overly inflamed environment. Because if it is an overly inflamed environment, then the stem cell itself has the ability to produce those anti-inflammatory proteins, and it kind of uses its energy up doing that. Whereas what we want our cell to do is to go in and modulate the area, interact with those cells, that cell-to-cell communication, to help stimulate and modulate that repair function.
Yeah, absolutely. So the cells that we're talking about then, just for my own sort of clarification, we're talking about MSCs, which are mesenchymal stem cells.
Or for American listeners, mesenchymal.
Yeah. So these are the cells from the mesoderm, which are multipotent. And the main functions, or the main functions that we're interested in, will be anti-inflammatory, will be immunomodulatory, and will be trophic, which basically means repair.
Yeah.
So the situation is, if I understand you correctly there, Greg, is that these cells, they are able to respond to the milieu in which they find themselves. So the environment around the cells makes a difference to how they function. So if it's an acutely inflammatory situation, then these cells are going to behave differently. And then the secretome, the products that they produce, the cytokines and growth factors and so forth, is going to be different from maybe if it's a chronic situation or some other pathology that's going on. These cells have the ability to change their function according to where they are and what they need to do.
Absolutely. I mean, we know that, especially in a soft tissue situation, they do respond to chemokine. They will migrate to an area of damage. That's the other thing that we need to take into consideration, is that if we have an overly inflamed environment, they won't do that. They'll kind of deal with the inflammatory soup that they're now in. They'll try and combat that. Whereas if we do have soft tissue damage, we see this in fact, Frank Barry wrote a great paper years ago on meniscal tears and the mesenchymal cell's ability to obviously migrate to that chemotactic response in the meniscus and take up residence there, not turning into tissue, but to do exactly what you said, was to stimulate. And in fact, that was one of the first papers way back in all of the journey that we've all taken in tissue engineering, that showed that the amount of tissue that was formed in that damaged meniscus was greater than the amount that was injected in volumetric terms. So this really led us in the pathway to go, this is stimulating tissue repair. This tissue would not repair without such stimulation. And it wasn't a 1-for-1, which is what we thought way back in the beginning. You know, I put in 0.5 ml of stem cells, I'll get 0.5 cubic centimetre of tissue. Not quite the contrary. That, I suppose when it comes to stem cells, the other big unanswered question, I don't think we'll ever get the question, is there an ideal dose? Do we get, X thousands, 100,000, millions of cells will create amount of tissue? We don't know that question. We're kind of pitching in the middle somewhere. But what we do know is that if you allow the environment to be more adaptive towards modulatory, then your dose is less of an issue. They will do the job in the tissue that they will stimulate to grow, will grow.
Yeah, absolutely. Yeah. So those MSCs, if we can call them that for short, would you recommend that we use those on their own, or is there anything that we should add in addition to those MSCs when we inject them into the joint?
Yeah, so joint is different to, say, a soft tissue tendon injury. I know the tendon injury, the work that I did with Professor Roger Smith at the RPC, we were always worried that if you had a carrier for the cells, and that's the other thing, these cells need a carrier to get there because they're quite small in volume. So the carrier vehicle was going to be one, and we used the bone marrow supernatant because it was less fibrogenic. It had less fibrogenic growth factors in it. And it was always a concern of ours that if you had something anabolically stimulating or modulating like a cell, but you had something equally trying to fight you, that would be pro-fibrogenic. You're kind of combating one against the other. But I think over the years, we've come to terms with PRP actually being quite a nice accompaniment to stem cells. We've seen some evidence that the response is good. Now, interestingly there is that there are growth factors within PRP, TGF-beta is one, that actually upregulates chemotaxis. So does that aid in the grafting and migration of the cells if those growth factors can work on damaged tissues and, say, upregulate the chemotaxis? We also have a situation where upregulating chemotaxis in damaged tissue increases circulatory cells. So you're kind of hitting it from both angles. You're going to get this migration of autogenous MSCs migrating to this area at the same time that you have this, injection of MSCs hitting both sides.
Yeah, I agree with that. And I'll add one further thing, that the fibrin that's within the PRP actually can form a clot or a scaffold.
Yes.
And MSCs, they are a kind of cell that normally occupies a niche within the body, whether it be in the bone marrow or when they're pericytes, and they're always attached to something. They like to have attachments, okay, in a three-dimensional sort of way. So when you look at an MSC under the microscope, it looks like a fibroblast. It's got multiple processes, and these processes have the ability to adhere. One of the things that distinguishes the MSCs in the lab is that they adhere to surfaces. So when you're culturing MSCs, one of the things you do when you're purifying, passaging them, is you can wash away everything else, and what you're left with on the bottom of the dish attached are your MSCs. So they've got this physical sort of predilection towards forming these attachments to surfaces. So the theory is that if you have PRP in addition to your MSCs, and that PRP forms a clot, which is a three-dimensional network, then those MSCs can anchor and stay in the place where you put them for longer. They're going to be happier because it's more like their preferred natural environment. And that way they're probably going to perform their functions and secrete what they secrete better than if they didn't have that physical environment. It's not a chemical thing, it's a physical thing.
Absolutely.
Yeah.
Is it worth touching on autologous versus allogeneic, what is available today?
We can go there if you wish.
I think for the listeners, it's to understand that we do have the two available. So
when we're talking about MSCs and where they come from, they can be any of the following. They can be autologous. And autologous means that the patient and the recipient is the same animal. So if you're taking, say, fat-derived MSCs from your dog and then purifying them, expanding them, and then injecting them back into the same dog, that's autologous. You can have allogeneic, in which case the process is the same, except the recipient is a different dog. Okay. We'll come to xenogeneic. This is allogeneic.
Oh, sorry.
Yeah. Okay. And third, so we don't have we do have autologous in the UK. We don't have allogeneic yet. Okay. Third, we can have xenogeneic, which means that you've got two different species involved. The target species is a different from the donor species. So we have such a product, which is dog stem, which is an equine umbilical cord MSC. So an adult MSC from the equine umbilical cord that is injected into dogs, licensed for use in dogs' joints. And there's one further one which we don't have, but we may have at some point, which is iPSC, which is an induced pluripotent cell. Is everybody familiar with iPSCs? Yeah, so this is one that has been produced by reversing the normal evolution of cells. Normally, cells start off with more stemness, and then they gradually differentiate and differentiate and differentiate down to maybe a specialized adult cell. Well, if the process is reversed, then you can get back to what is called an induced pluripotent cell. So that is also a theoretical possibility for an orthobiologic. So to try to answer your question there, Greg, we basically have two choices on MSCs. In the UK, we have autologous, in which you harvest a tissue, which is usually, in our case, adipose tissue, as our source of cells. It's not the fat cells that we're after. It's the cells around the capillaries, which are called pericytes. And we believe that pericytes and MSCs are very closely related, or they may be one and the same. Those are the cells that we take, those are the cells that we need. And that's the autologous way. And then we have this xenogenic product, which is dog stem, which is licensed in the UK and the European Union, which is the equine umbilical cord cell. Now, the equine umbilical cord cell has a few limitations on its data sheet. Number one being that you can only inject it into the elbow and into the hip. Those are the only locations for which it's licensed. So if you wanted to inject it into a carpus or a stifle, you're off label. The second limitation is that you can only use it once, according to the data sheet. So if you wanted to top up that stifle that you've injected off label in 6 to 12 months or whatever, you're also doubly off label, because you're not meant to do that according to the data sheet. Now, it's not really logical, because if it works in a hip, it should work in a stifle, it should work in a hock, it should work anywhere, because it's the same patient. But the license does not allow you to do that legally.
Yeah, the other limitation was that if you are going to use dog stem, it should not be used in conjunction with any other intra-articular medication. Clearly that's been done because, like all pharmaceuticals, if you are going to use anything concurrent, especially in such a local environment, your clinical studies would have to show that should be done. So really what they're doing is they haven't included PRP in their clinical studies for their marketing authorization. So it's actually easier to go, do not inject with anything, so it doesn't become the status quo. So absolutely, the company behind it is basically saying, look, we cannot condone the use of it. And that's where that comes from. Absolutely. Quick question on the xenogenic. Should we be worried about immune response of another species? I mean, how does that not work or work? Why can we use a xenogenic cell?
That's a great question. And when I first heard that this product was going to be released, that was my immediate thought as well. Surely, if you've got a foreign cell from a different species, then that's going to be way more immunogenic than allogeneic or even autologous. And you'd have thought that would be the case. Now, I think it comes back to the nature of MSCs, and MSCs are what we call well, there are various ways that you can articulate this, but the phrase is hypoimmunogenic. Or immune privileged. So
immunologically inert.
Yes, exactly. So cells have an identity card, if you like. They have surface proteins, and we're really talking about mostly the MHC2. So if you have MHC2 on your surface, then that very readily identifies you as foreign. Okay, so if you were to inject a cell into a joint and it had an MHC2, then the innate immune system would detect that immediately and eliminate the cell. If you don't have that MHC2, then that allows you as an invading cell to go under the radar undetected, and you don't get cleaned up immediately by the immune system. So I think it's not to do with so much that it's a different species. I think it's to do with that those cell surface markers are absent. And it doesn't seem to matter which species you come from. I'm doing a study on cancer in Singapore where we're actually using cells to treat cancer in dogs, and the cells we're using are human cells. So also xenogenic. So I think that would be my answer. And it's been through the regulations, it's been through the VMD, it's got its license. So it doesn't seem to have that risk of immunogenicity.
Yeah. So how can you help as an oral clinician decide when would you use an allo over autologous, making that decision? What's your decision pathway on that?
That's a very good question. Okay. So let's look at both then. So if you've got... if you're dealing with autologous, then in order to do autologous stem cells, you need to have a tissue source. The usual tissue source is fatty tissue, and the usual way of collecting that is at surgery. So you need to do an operation. Most of us nowadays use falciform fat. So we do a mini laparotomy, take out the falciform fat, take that fat to the lab, aseptically, obviously. Then once the lab has done all the clever stuff, then we get the cells back, and then under sedation, we inject the joint maybe a month later. So that's a two-stage process. So you need to have an anesthetic. You need to collect the tissue. So there is an upside, because once you've collected the tissue and extracted and purified and expanded those cells, they can be cryobanked. So you can have a supply for the future and maybe for the rest of the dog's life. Okay, so you can have multiple top-ups available. So it's got disadvantages and advantages. So if you've got an animal who's young enough and fit enough and healthy enough to have a general anesthetic, then doing autologous makes sense, and it's kind of future-proofed, because then you're collecting more cells for the future and banking them. Plus, it doesn't matter which joints you inject them into, or which muscles or tendons or wherever you inject them, doesn't matter. And it doesn't matter how many joints. So if you've got 3 or 4 joints affected, you can get enough cells to do all of that and repeat that multiple times. So that makes for a very nice way of doing your orthobiologic, because of all of those, with obviously the limitation that it's expensive and it needs surgery.
I suppose in the field of disease management, we know that this is not a treatment that's going to eradicate the disease.
Mm-hmm.
You know, if we go into the joint with a stem cell, there will come a point in time we're going to need to go back in again.
Exactly. So
you're kind of lining that patient up for its future treatments.
Absolutely. Which makes it a very attractive way to go.
Yeah.
Okay. So what are the advantages of having the equine umbilical cord orthobiologic? Well, firstly, you don't need to do an operation, because the cells have already been produced, and you can buy the cells in a vial. Okay, they're off the shelf. We say off the shelf. They're out of the fridge, and they last about a week or 2 in your fridge. So you have to order them specifically for each patient. But once you've got them in your fridge, then you can sedate your patient and inject either an elbow or a hip. So it has that advantage, not more than once. So there's the big downside. It's not more than once, and it's only an elbow or a hip. Or I'm never sure whether it's just because you can only do it on one occasion. Does that mean that if you had an elbow and a hip, or 2 elbows and 2 hips, could you inject both at the same time? I'm guessing you could, but it has that downside. So let's say you had an elderly patient, and the owner was dead against general anesthesia, but wanted a quick orthobiologic, would accept sedation, and it was an elbow or a hip, then that's where that product would be ideal. If you've got more joints affected, you've got a younger patient, they can have an operation, and you want to future-proof by cryobanking, then I would go autologous.
Yeah. Okay. So I think we've kind of covered the biologics extensively enough for the listeners. Let's touch on some non-biological areas that we haven't touched on yet, and I'm going to go into products such as hyaluronic acid, or even what is now becoming a little bit more popular is the hydrogels, polacrylamide hydrogels. So HA, been around a long time, hyaluronic acid. We've got single chain, cross-linked chain. It has anti-inflammatory properties. It used to be, the old style HA was produced from rooster comb. That was where it extracted. It's now done through bacterial fermentation. Relatively inexpensive. I know, again, going back to equine medicine, it's used quite routinely as a viscose supplement. Do you see HAs having a role in canine OA management?
Great question. I don't really have much experience with it, so I don't really know how to answer that. Theoretically, yes. It would seem to be useful. I guess when you need additional lubrication, that would probably be the place, I would guess. And it is compatible with certain PRPs as well.
Yes, that's right.
So, there are PRP products that, by virtue of the fact that it's within the tube when you make the PRP, you actually get a combination of both.
Definitely.
So I think they are synergistic in that way. And certainly in the human, it's a very popular injection
It's
for
very
popular.
The first choice of product.
Yeah, exactly. And if you look at the human trials, they're always comparing HA versus PRP.
Yes.
Which is better? And nobody can seem to agree.
It seems to be the go-to comparison for all clinical studies these days. Is that what is your control group?
Exactly.
It's a HA injection.
Exactly.
There are veterinary licensed HAs, so we do have those. They're licensed for equine. I do believe there is no licensed canine HA.
As far as I know.
Yeah, I don't think there is, but you can get a hold of licensed equine HA. One thing to bear in mind with HA is the autogenous weight of that, the molecular weight of the HA. We look at the autogenous HA in a joint is around 1.5 to 2 million Dalton. We need to be mindful of that when we're using a HA, that we are not introducing HA that's any less than that. And there are HAs in the market that are less. We know that they have been associated with irritation in the joint, and that's because they break down quite quickly. They're a single chain HA, so the joint has got to deal with that almost like a foreign body. So in an inflamed joint, we certainly don't want to steer up what's going on or make the situation any worse. So I would certainly steer away from a HA of a low molecular weight in an inflamed joint. Whilst that might seem an appropriate fit for a supplement, a viscosupplementation or aid in lubrication, we know that HA has a degree of anti-inflammatory effect. It can sit on the cell surface receptors of the chondrocyte, kind of has that binding affinity as well. But I think I would rather use it in perhaps a disease modification or in between treatments, perhaps just to aid the health of a joint, but certainly not as a main treatment in canine OA, which we tend to see in the age one.
Yeah.
Hydrogels. Polacrylamide hydrogels.
Yeah,
there's a couple on the market now.
Once again, I don't really have experience with those, so I'll defer to you on that one. I think you probably know more about it than I do.
Yeah, so what the polacrylamide hydrogels are trying to achieve is providing a scaffold for or aiding the synovial tissue to repair. It has no stimulatory effect. It's an inert substance. We talked about how PRP can create a scaffold. We know that tissue needs a scaffold. Whatever we do, if we're introducing a cell or introducing any material, if we have cell-to-cell interaction, we have cues going on, but we also need that scaffold in order for tissue to repair. And that's what the hydrogels essentially provide. So we know that the hydrogels that are on the market, there's a licensed equine one. Essentially what it does is it creates a foreign body reaction. So by introducing it into the joint, it lines the synovial membrane. Your macrophages try to get rid of it through their sort of normal phagocytosis activity, but the molecule's too big. It can't. So what it actually ends up doing is encapsulating it. By encapsulating it, the gel is then taken backwards into the actual intima layer, the subintima layer, where it acts then as a scaffold. So the joint becomes a little bit irritated for a few days post-injection through that foreign body reaction. But once it's there, it's permanent. Mm-hmm. So where you've got damaged synovial membrane, typically through MMP activity, we talked about that before, your matrix metalloproteases do hit your synovial membrane, you lose tissue. So if we look at, and if you're able to scope a joint, you would see your synovial membrane, and we now can grade the synovial damage up to grade 3. So that synovitis, the chronic stage, could be a grade 3. And we see loss of tissue, quite a lot of loss of tissue. And if we know we've got loss of tissue, then we've lost production. Mm-hmm. So if we can aid the regeneration, not through modulation or stimulation, but by providing a scaffold, then we can help the synovial membrane recover because it is a soft tissue. So that's how the hydrogels work. I suppose the secondary action that it's got is by being permanently embedded within the subintima and the joint capsule, it aids in elastin modulus. Mm-hmm. So those patients that have got I wouldn't call it a mechanical lameness, but we know that the restriction of the joint through that scarring of the joint capsule triggering those mechanoreceptors that you get, if we can increase the range of motion before those receptors kick in, we see this when we measure patients with goniometry, pre and post the use of a hydrogel, then we know their range of motion increases, and that also can aid in the overall recovery of the patient because you've got that increased mobility.
Yeah. It does seem a little bit counterintuitive that you might be injecting a product that you know causes a foreign body reaction.
Yeah, absolutely. But that's where you're looking at it in the stabilized patient, looking at modification.
Yeah.
You would not use a hydrogel in a destabilized patient. You would not reach for that first. This is where you really need to decide which tool to use so that we don't end up using the wrong tool at the wrong time, initiating what could be an adverse event because we've used the wrong tool at the wrong time.
Excellent. Okay, well, I think we've summarized things quite nicely. Does anybody have any questions or comments about what we've discussed so far?
Is there any situations where you would choose to use a hydrogel over your stem cells?
So for listeners who didn't hear that, is there ever a situation where we would use a hydrogel over a stem cell? I guess the immediate one that comes to mind is the more chronic aged patient, okay, where, and I say this with all of the intra-articular medications, the first thing you must try to do is go, what am I trying to achieve? What is the end result that I'm actually trying to achieve? Now, that could be the status of the joint. It could be trying to alter the local environment, or what am I trying to do for the patient? Ultimately, what am I trying to do with the patient? So if we look at your aged patient that, say, is refractory to medication, we're getting to that almost end of life stage, but there is a situation where it could tolerate a sedation, not a huge general anesthetic. That is the one that I would tend to go for the hydrogel, because what we're actually doing is actually just dealing with a fibrotic joint capsule that we can increase the elastin modulus. So I've got an increased range of motion. So the quality of life, the ability to have an extended range of motion is my end point. I know that I don't have long with this patient to try and change things to create I'm not having the same strategy in a 3-year-old dog. If I had that aged dog, then just making the joint feel more comfortable. I've done nothing about regenerating the joint. It is not inflamed. It's responding. We talked about a chronic patient before. It's responding to that adaptive situation in the joint, and quite often it's restricted range of motion due to a fibrotic joint capsule. So changing that elastic modulus is probably the angle that you would go on that one. In equine medicine, we tend to use it early on. So again, that's the only other area that I would go to. If, say, you're working with a sport dog, working dog, where you're actually dealing with a synovitis, we know the synovial tissue is under attack. You have probably very little or nothing on imaging. In fact, the joint itself looks fairly good. But we know we've got chronic synovitis. You can see that. So in that situation, if I know I've got damaged tissue, then you might want to go hydrogel on that one. One of the key aspects there is that the synovial tissue struggles with something which is quite unique, in that the loss of the synovial tissue is a direct response to what the MMPs are doing. But where you lose synovial tissue, what replaces it is synovial fluid. Synovial fluid is tissue growth inhibiting. So how do I expect a tissue to regrow in the presence of something that is tissue growth inhibiting? It struggles. So that sort of acute to chronic synovitis is really difficult and the synovial tissue really does struggle to get over it. It does over time. But one thing that the hydrogels have got the ability to do is to displace that synovial fluid in the initial as it's being encapsulated. So, and then creating that scaffold allows the joint to recover. And there's a few published studies showing that, how it can respond to that by not dealing with inflammation, but allowing the synovial membrane to respond to its normal ability or attempt probably better to recover.
Mhm.
So those are the two angles, and I'll probably leave the middle alone and go for a biologic.
Excellent. So, would it be possible to just ask you guys who's using any intra-articular injections?
Okay.
And what sort of things are you using?
I've used both the dog stem and autologous stem cells and PRP.
Right. So, for the audience, that was equine umbilical cord MSCs, autologous MSCs, and PRP. And what has been, may I ask, your experience with these? Has it been positive? Has it been negative? Has it been mediocre? What would you say?
Generally positive. My experience of the equine stem cells was mediocre, I would say. I didn't get the length of effect that I wanted.
Can I ask what stage you injected?
So it was towards the more chronic end. It was my first experience really of intra-articular injections, so it was one
You reserved it for
later.
more of a salvage patient?
Yeah.
Okay.
It was a patient that had previously had PRP a couple of years before.
Yeah.
And we were trying dog stem on that patient. So I wouldn't write off dog stem based on that experience, because I do think it was later on than I would now do intra-articular injections. But I like the ability to combine the PRP with the autologous, so I don't think I would use dog stem unless it was an old patient where I knew it wouldn't need a second treatment.
Sure.
Absolutely. Good. Excellent. So does anybody have any other comments or questions for the panel?
What kind of duration of effects will you get from the autologous stem cells?
Good question. So typically it's going to be a long-term treatment. So the duration of action, even though when you inject the MSCs, they don't survive for long. Their action is referred to as a kind of hit and run. So they have a big effect on the joint and on the body, but they don't survive themselves. So that's why it's referred to as a hit and run. Whatever processes they're up-regulating, down-regulating and modulating, the effects can be long-standing. So
isn't that the advantage of an intra-articular medication per se?
Yes.
Because you get the same effect with a steroid.
Yeah.
You know, triamcinolone only lasts for 56 days. Mm-hmm. Symptom relief can go for 5-6 months.
Yeah. I'll take your word for that because I don't have experience. I do have experience with the orthobiologics, and they do last a long time. So normally, if you're thinking about when should I top up the treatment, it's often around about a year, 18 months or 2 years. So I think most of the time with autologous, you're getting at least a year's worth of effect, of positive effect. So the animal is less lame, the animal is more comfortable, you're using fewer medications. So adding in PRP probably extends that further.
I'm going to throw in a question that could lead to another podcast. So we try and little answer goes, when to re-inject? We know that we've got a disease that's being managed. We know the disease is present. Do we need to wait until it's symptomatic again before we re-inject? Is there a time point pre-destabilization again that is optimal to inject?
That's a great question. The short answer is this. Can we ethically justify injecting an animal who's not showing any pain, signs of lameness, or effect from the OA? Because we feel that within a few months, the OA is going to return with a vengeance and the dog's going to be in pain. So my opinion on that is, no, you cannot ethically inject a dog who's apparently got a completely quiescent, settled down joint. They're off medication, because I feel that in the future that it's going to flare up again and we're going to be back to square one. So I wouldn't do that.
So we can inject insulin for a diabetic patient without symptoms.
I'm not an internal medicine specialist.
I know, but we talk about ethics here. we've got disease management.
Yeah.
Why are we allowing the patient to destabilize, therefore actually increasing the disease situation by allowing it to destabilize, showing symptomatic, which is actually further pathology, before we can intervene?
I agree. This is probably another podcast.
That's what I'm saying. Yeah.
So
This is where I think we should take biologics.
I think we should
all the time.
I think we should.
Is there a management time?
I think we should. I think we should.
Time.
Yeah.
Should we intervene 7-8 months?
Yeah.
And
Absolutely.
that's the treatment time.
Possibly. And on that podcast, probably we should get Andy Armitage back, and he can field the difficult questions.
Okay.
How would that be?
Yeah.
Why is it not more widely used in humans at the moment? Stem cells, I mean.
It is.
Stem cell treatment.
It is. So what we did touch on, we're kind of taking the time up for a podcast. There are patient-side fractions that you can do. You can do fat-derived stromal fractions. You've got bone marrow aspirate concentrates. These are things that you can do in an outpatient department. There are clinics in London that you can go to. It's only available in private. It's not available in the NHS. And that is still regarded as a stem cell treatment because you are removing those nucleated cells and you're administering on the patient side. So it's more adipose than it is bone marrow, and it is being used in sports medicine as well.
And if you're on LinkedIn, you can follow Vet Stem Cell Hub, where there's loads more information on the human as well as the veterinary side.
A good friend of mine, Paul Lee, Professor Paul Lee, he's a big stem cell advocate, human orthopaedic surgeon. He uses a lot of stem cells.
Yeah, but I agree with Greg. They are mostly the patient side.
Yeah.
So they're not cultured cells, not like we have. They're more patient side, autologous, like lipogems, which is a stromal vascular fraction, BMAC, which is a bone marrow aspirate concentrate.
Do you have any experience using any of these intra-articulars in cats?
Cats. Good one. We at MSK Vets, we have done PRP in cats, and we've used hydrogels in cats. I think with cats, with the stem cell side of things, especially autologous, it's difficult harvesting tissue. And PRP is even challenging. That tends to be the issue there. But going back to one of our early statements, diagnosis of OA in cats is really under considered. It's a big area for the VOA to get into. We'll be doing that over the next couple of years. So we don't see a lot of cats coming forward for OA treatment. That's probably one of the problems.
Yeah, I've treated one cat with MSCs. This cat was a cat with adiposity, with obesity, and this cat was a three-legged cat, and on the remaining hind leg had a very osteoarthritic stifle. So with that cat, harvesting the tissue wasn't difficult, and we did get it cultured up, and we did inject it into that remaining knee with good effect. So yes, you can.
Thanks, everybody.
Yeah, absolutely. No problem. So that was the VOA podcast. Thank you all for attending this live session, and we look forward to seeing you all at VOACON 26.
Thank you.
Thanks for tuning in to the Nupsala Podcast. This is one of many insightful episodes that we have in store for you. You can stream the episodes on Spotify, Apple Podcasts and Amazon Music. Simply search the Nupsala Podcast. You can also watch on YouTube or directly at nupsala-learning.co.uk. If you'd like to stay up to date with all our latest content, please follow us on social media, where we always post when a new episode launches. All the links and details are in the bio. Thank you.